Prognostication for myeloproliferative neoplasms, or MPNs, is affected by genetic profiling. Genetic profiling or molecular testing has become a routine part in academic centers in assessment, particularly of one type of myeloproliferative neoplasm patients, myelofibrosis. In myelofibrosis, which is the deadliest of all, with the median survival of about 5 to 7 years, one does have a prognostic scoring system in existence to prognosticate who has a short life expectancy, shorter than 5 years, to refer that patient to a bone marrow transplant, which is then justifiable. With the implementation of additional genetic testing results, like mutations in IDH or EZH2 or SXL1, I'm just giving you a few, those bad prognostic genetic modifiers or genetic mutations add information to our ability to prognosticate properly and identify patients perhaps earlier for intervention with bone marrow transplant. In other diseases, I'm talking about essential thrombocythemia and polycythemia vera, prognostication, particularly in essential thrombocythemia, has been enhanced by addition of information whether calreticulin mutation is present or not. That's only one, and it's one of the driver mutations in that condition. In ET and PV, we prognosticate to identify patients that are at the risk of blood clotting. And ET patients that have calreticulin mutation have a much less risk of blood clotting, which is valuable for doctors to know, because then aggressiveness of the therapy is less than otherwise. Rationale to prognosticate in ET and PV is to identify patients within group of ET or PV patients that are at a higher risk of having a blood clot than otherwise. So traditionally in ET and PV, you would utilize two factors to say whether that ET or PV patient is at a high risk of a blood clot or not, which would be age over 60 or a history of blood clot. Now the change has been made, significant change in prognostication of ET patients, by the addition of another factor, which is the molecular profile in terms of which of the driver mutations, and we know 60% have JAK2, 30% have calreticulin, and 10 have MPL mutation. Which of the driver mutations that ET patient has? And if it's calreticulin, then that patient is as much less of a risk for having a blood clot. And if they are otherwise low risk by standard prognostication and have a calreticulin mutation, you would not even give them aspirin. If there's by standard prognostication high risk, but they are calreticulin positive high risk patients, you would not even give them cytoreductive therapy, which you would otherwise do. So information on calreticulin positive or negative status is a third factor for prognostication in ET. In PV, we did not make such a change yet. There are a number of emerging therapies for myeloproliferative neoplasms. When we talk about ET and PV, essential thrombocythemia and polycythemia vera, we are particularly happy with the information that in Europe, about 6 months ago, there was a new development of approval of a ROPEG interferon, which is a long-acting interferon as a frontline therapy for our patients with PV that needs cytoreductive therapy. Remember, these would be patients that are older than 60 or history of blood clot. They need a cytoreductive therapy to lower the risk of thrombosis. Traditionally, we have used hydroxyurea, but now we have ROPEG interferon. Hopefully, this will come over here in the United States. For myelofibrosis, 3 months ago, there was approval here in the United States, not in Europe yet, of another JAK inhibitor called fedratinib as a therapy for patients with intermediate to and high-risk myelofibrosis, which is the second JAK inhibitor in our armamentarium of therapies for myelofibrosis patients. So these are approved in different parts of the globe. But there are a number of investigational agents for myelofibrosis, like luspatercept for anemia, CPI 610, that's investigational agents, BET inhibitor for myelofibrosis. There are a number of them, and it's very interesting here at our ASH meeting to follow up what is going to be approved soon for our myelofibrosis patients that are the most aggressive patients. For essential thrombocythemia and polycythemia vera, when we talk about initiation of therapy, factors that influence what we do are particularly related to risk of thrombosis. That would be age over 60 and history of blood clotting, and for ET patients, whether they are calreticulin positive or not. Because prognostication is related to the overall risk of developing an event that can lead to untimely death. The blood clot is usually the cause of dying in ET and PV. The other situation that we have is with the patients with myelofibrosis. This is different. In that situation, we prognosticate to identify patients that have a short life expectancy to send them to the bone marrow transplant. When we decide on a therapy, then we look at the characteristics of the patients. I'm talking about presence of anemia, presence of symptomatic splenomegaly, general systemic symptoms like bone aches and pains, night sweating, low-grade fevers. We go by the signs and symptoms and treat them with JAK inhibitors, ruxolitinib, or now newly diagnosed fedratinib for symptoms in the spleen, or for anemia, one of the traditional factors like erythropoietin stimulating agents, thalidomide, or danazol. These are off-label use of anemia drugs. We don't have approved drug for anemia as of yet. Maybe we'll have soon one of those approved, including some new JAK inhibitors in phase 3 studies like momelotinib and pacritinib, but this is where we are right now. So treatment in myelofibrosis is based on the clinical characteristics, basically signs and symptoms. Management of the patients with myeloproliferative neoplasms is the key to a success. If we are talking about management of patients with ET and PV, that is relatively simple as compared to the complexity of managing patients with myelofibrosis. In ET and PV, we utilize usually one cytoreductive therapy to decrease the blood cell count if it's indicated, and that is then either hydroxyurea or interferon or anagrelide. There are several medications that are utilized on the individual basis with a great success. We usually control the blood cell count without major toxicities in about 3/4 of the patients. If we have toxicities, then, for example, in polycythemia vera, ruxolitinib, a JAK inhibitor, has been approved as a second-line therapy after hydrea to control those symptoms and blood cell count if they're not controlled very well. So you have ruxolitinib on top of everything else with a very high success rate. In myelofibrosis, it's more difficult because patients have multiple symptoms. So if you just talk about the major 3 problems, anemia, big spleen, and poor quality of life, we would be utilizing JAK inhibitors for symptoms and spleen and add, in many cases, anemia drug, and then modify the doses and try to optimize delivery of these medications to the highest possible safe level, the highest possible dose of a JAK inhibitor, for example, to counteract the spleen and symptoms to the greatest degree.